All right, guys, let's get busy talking about hypertension in pregnancy. When it comes to this topic, we're going to approach it as a spectrum. So our most mild disease is going to be here, and as we get more severe disease, we're going to move further down the table. I also want to mention that we're going to approach it by talking about the presentation criteria that define each type of hypertension, as well as the pathophysiology about what causes each type, and also talk about the management at each stage. And I want you guys to be aware that all of the pathophysiology here is going to be related to abnormal vasculature, so keep that in mind as we approach this topic. Let's go ahead and start off by talking about chronic hypertension. And when it comes to chronic hypertension, we first need to have a definition of what we're considering hypertension when talking about hypertension in pregnancy. So our definition of hypertension is going to be blood pressure readings of 140/90, and we need to have two of those in two different time points, hopefully more than 4 hours apart. So if a patient has that, then they are now qualifying as hypertensive. So let's talk about chronic hypertension, which is going to be a patient who has hypertension as set by our definition before pregnancy even starts. So this is going to be things from like obesity or diabetes or a number of other conditions that can cause hypertension, and now they happen to be pregnant. So these patients are going to be hypertensive up to pregnancy, and then within the first 20 weeks, and then they're going to go through pregnancy hypertensive, and then after they deliver their baby, they're still going to have hypertension after pregnancy. So this is by definition hypertension prior to 20 weeks, and then our hypertension is going to persist after delivery of the baby. Now let's contrast this with our gestational hypertension, which I'm going to highlight here in blue, and this is going to be when we have hypertension when we start pregnancy. So this is specifically going to be developing after 20 weeks of pregnancy. So this would be a patient who was previously normotensive, and then after 20 weeks of pregnancy, they begin to become hypertensive by our definition. And we expect these people to maintain their levels of hypertension throughout pregnancy, and then after delivery of their fetus, their hypertension should regress. They should go back to their normal baseline blood pressure after 6 weeks. So that's important, that they should return to their normal state of previously healthy blood pressure. We expect an increased risk of gestational hypertension in our pregnancies with multiple gestations because there is a lot more blood to move around, and this connects to our pathophysiology of gestational hypertension, which is going to be due to increased blood volume. So when you are having a baby, that baby needs blood, so you have to create new blood and new vasculature, and so you're pumping against a lot more pressure, and that's what can cause this gestational hypertension to occur. So essentially increasing our circulatory load, and this is all about vasculature. So you're going to start sensing this theme that changes in vasculature are going to lead to hypertension in our parent. Let's talk a little bit about management of these two conditions. I'm going to highlight this management in yellow because it applies to both our chronic hypertensive patients during pregnancy and our gestational hypertensive patients during pregnancy. So the antihypertensives that we have to choose from are 4, and they're going to be hydralazine, labetalol, methyldopa, and nifedipine. And there's a great mnemonic for remembering these, and is hypertensive moms love nifedipine. So these are going to be safe in pregnancy. They're not going to cause any teratogenic effects, and choosing the one that you end up choosing is just going to vary on the other health conditions the mother may have and other history or allergies that she might carry. And then we're going to go ahead and deliver our fetuses at 37 to 39 weeks in our patients who have hypertension during pregnancy. Let's move on now to talk about preeclampsia, which is going to be the next level of severity of hypertensive disease in pregnancy. And this, by definition, is going to be someone who has gestational hypertension with the addition of proteinuria or organ dysfunction. Now, proteinuria is representing organ dysfunction within the kidney specifically. Our kidneys are very sensitive to changes in blood flow, so vascular changes due to blood pressure changes can really affect the kidney, and they're going to manifest this as protein in the urine. So it's important to regularly get urinalysis on our pregnant patients looking for protein in the urine. However, we can also see organ dysfunction in terms of other systems, so we can start to see some pulmonary deficits like pulmonary effusions due to abnormal pressures throughout the vasculature. Also, we could see some neurological deficits, perhaps things like paresthesias or altered mental status. These are all classic signs of organ dysfunction. And why does preeclampsia happen? It's going to be because we have abnormal placental spiral arteries. So normally our spiral arteries are going to incorporate into our uterine wall and connect it to the placenta, but sometimes this placental artery incorporation can go awry, and it can start leading to things like like vasospasm. So this vasospasm is going to cause placental vasoconstriction, and eventually it's going to cause placental ischemia. And the placenta is going to be releasing chemical mediators and responding to this ischemia and vasoconstriction. And essentially what's going to happen is we are going to get hypertensive or increased systemic vascular resistance throughout the rest of the body. And this is the pathophysiology of what happens in preeclampsia, and these vascular aberrations throughout the body are going to start affecting all the systems, and our canary in the coal mine in this case is usually going to be our kidneys in the form of proteinuria. So let's talk about the next stage, which is going to be eclampsia. And that is going to be preeclampsia, which was the definition we just discussed, with the addition of seizures. So we talked about organ dysfunction in terms of like altered mental status or paresthesias relating to the neurosystem. However, as soon as these patients start to develop seizures, we now reclassify this as eclampsia. And so the pathophysiology is the same. It's just that preeclampsia has now morphed into eclampsia. And so it's important that we talk about why this is happening in the first place, like what connects these disease processes in terms of risk factors. And it's going to be things like immunological intolerance, specifically antiphospholipid syndrome is a big one that they like to mention on exam day. I've abbreviated it here as APS. Also improper implantation, which makes total sense because we know that the spiral artery, placental arteries are like the base of all this pathophysiology. And then also inflammatory changes, advanced age, and previous hypertension can all contribute and increase your risk of developing preeclampsia/eclampsia. And now let's move on to talk about the management of these two conditions, and it's going to be antihypertensives, which we talked about with our special mnemonic, the options that we have. And we also need to give our patients magnesium sulfate, and this is because magnesium sulfate is going to be neuroprotective, so it's going to help prevent some of those seizures that are going to occur in eclampsia. And these seizures are occurring because of vasoconstriction and vasorelease and more vasoconstriction in the vasculature supplying our brain. And so if we give mag sulfate, it increases that seizure threshold and helps prevent mothers transitioning from preeclampsia to eclampsia. So as soon as a patient qualifies for preeclampsia, they need to be prophylaxed with magnesium sulfate. Additionally, we want to pursue prompt delivery. So delivering this fetus as soon as possible is going to be really helpful in terms of relieving the root problem, which is going to be those placental arteries. So once we get those placenta out, it's going to improve the eclampsia and the preeclampsia that could be happening. In terms of maternal complications, we talked about renal failure. We talked about the fact that we can have vasoconstriction in the brain, and this can actually lead to hemorrhage and cause stroke. We can also see ARDS, which is going to be a pulmonary complication. And then in terms of fetal complications, we can have uteroplacental insufficiency, which is going to lead to growth restriction in our fetus, as well as placental abruption, because it's, again, all about that vasculature. Let's wrap up now by talking about our most severe pathology, which is going to be HELLP syndrome. And HELLP syndrome is a disease process that is written as a mnemonic, and it stands for hemolysis, elevated liver enzymes, and low platelets. And this is a constellation of findings in patients who are at the end of pregnancy. And usually it is accompanied by things like eclampsia and hypertension. However, it can also happen independently of hypertension, preeclampsia, and eclampsia. So as soon as our patients in late stages of pregnancy acquire these lab abnormalities, they now qualify as having HELLP syndrome. And the HELLP syndrome pathophysiology is very similar. We're going to have like vasoconstriction, vasospasm in our liver, and it's going to cause liver thrombotic microangiopathy. And so our liver is basically having a bunch of microclots all throughout, and it's going to lead to liver failure. And we know that our liver is a major synthetic organ, and it's responsible for making a lot of enzymes. It's a big reservoir for platelets. And so as soon as our liver starts failing, we start to see these enzymatic lab abnormalities in the form of hemolysis, elevated liver enzymes, and low platelets. And so in terms of complications here, we can also have liver capsule hematomas from this vasospasm. We can get these breakages in these clots and these breakages in this vasculature, and it can cause these big collections of blood within the capsule of the liver, and this can lead to hypovolemic shock in the pregnant person. Also, Also, during this time, we can have tissue factor exposure, which is going to lead to DIC, which is a major complication. And so these people with HELLP syndrome need to have the baby delivered immediately in order to relieve these symptoms. This is a life-threatening emergency. So in terms of a high yield review, it's important to know that hypertension in pregnancy exists alongside of a spectrum. It's really important to know each of your definitions because they will be asked about on exam day. And if you can have your definitions memorized, then it just comes to understanding the basic pathophysiology of vasospasm and vasoconstriction throughout the body. These vasospasms, these vasoconstrictions are going to lead to organ failure across the body, which leads to all of the symptoms we mentioned, starting with the kidney as the canary in the coal mine, and then moving on to other systems like the lungs and the brain. So I hope you guys found this video helpful. I can't wait to see you guys in the next video.